the stress of surgery is your own adrenals then secrete epinephrine and norepinephrine. And like he just said, that's not what we want. So in the early post-op state, we were fighting against her own endogenous catecholamines. So she needed a ton of fluid to keep her left ventricle filled. Okay? And neo to give her some blood pressure because she was in low-grade cardiogenic shock. We couldn't do inotropes because that would have compounded the situation. So we gave her a ton of fluid, and then a few days later, once her adrenals calmed down and chillaxed a little bit, and we weren't fighting against nitrogen syndrome, we could then save the diuresis, get the volume off, not over diuresis, because we was back, with the SAM situation, but dry our lungs out. Okay. Because her lungs were getting fluffy and all that. So, mitral valve repair is where I see this stuff mostly. It's kind of the bane of our existence as a mitral surgeon. You get to the end of the operation and try to come off pump, and you got SAM. And SAM can actually cause mitral regurgitation too. It can be severe. Because you probably know the physiology better than I do. But
well, sure. Well, as I said, the SAM is going to pull the anterior mitral leaflet out of position in systole. And you lose coaptation. Good coaptation with the posterior leaflet. Yeah.
Even with the new valve, you're going to still
see that. A repaired valve. If we replace the valve, you can't have SAM. Okay. Because we remove the anterior leaflet when we replace the mitral valve. That's the extreme treatment for it. If all these attempts at repair and then the medical measures that Dr. Pulitzer mentioned don't help, then we have to go back and replace the valve. Or do other things like what's called escaping me the name of it. But I basically make an incision in the posterior leaflet and then sew it back shut because that reduces the height of the posterior leaflet. So who do we see this in mostly? People with small left ventricles. The little old lady is a setup for it. Especially a little old lady with hypertension. Big, thick left ventricle, small cavity. Those are the people that give us trouble. And treatment post-op is basically they're not on pill shadows, so everything will give us IV. Volume will put it first. You'll have a swan in. The numbers are low. CVP is low. You fill them up with fluid. If they're normal bulimic, they can look like someone in cardiogenic shock. Low CI, high PA pressures, etc. In that instance, you basically just want to give them neo for blood pressure support.
So if you do a repair, you're gonna see it already in the OR and know this isn't something that's going to develop, and we're going to call you.
Well, if they get dry post-op, they can develop. Despite us in the handoff saying it looks good.
Right.
It can develop. Okay. Depending on the state of hydration, and if they get tachycardic, for example, also.
Right.
Or if their endogenous catecholamine state goes up, things can change. Okay.
And vital sign-wise, are they hypotensive?
Hypotensive, yes.
In fact, this can be confused, until you get your echo. It could be confused. Other things that can cause this picture: subaortic membrane, valvular aortic stenosis, where patients may have the same kind of symptoms.
Okay.
And these also, they have in auscultation, they'll have a systolic murmur. It's usually at the left sternal border, and typically, it'll increase with Valsalva because you're increasing your venous return, and that's going to increase the flow velocity.
So the order of intravenous therapy for someone early post-op is volume of human or fluid, eosinophil, and then if you've restored blood pressure, give them IV beta blocker at that point. Because they'll tolerate it. To slow them down and to fight off any endogenous catecholamines. That's kind of the order of therapy after mitral valve repair.
I didn't have this patient. Was this discussed in the handoff that they took we should look for this patient?
Yes, it was.
It was discussed, like, preoperatively too. Okay, they call. Okay, so that all of the other
not know it until we did the echo post-op.
And she we sent her sheet. What they do?
Yeah, not the support visual.
Going into a repair, there's the one like the kind of anastomosing the anterior and posterior leaflets to make like the two tracks. Like, is that something you'll do if someone's at high risk ever? But like, there was one way to eliminate the risk of it by like basically doing like the mitral clip.
Sliding plastic. Oh, Alfieri stitch is the other way to do it.
Okay.
The Alfieri stitch is basically a stitch between the middle of the anterior leaflet to the tip of the middle of the posterior leaflet. That prevents the posterior leaflet then tethers the anterior leaflet from moving into the left ventricular outflow tract. Just sew them together. It does not create mitral stenosis if you're doing a small stitch. In fact, I had a kindred of Jehovah's Witnesses, a family that all had the exact same mitral lesion, really bad Barlow's valve. And I did them all through a minimally invasive approach. This was in another hospital where I used to work. And I knew they were all at risk for SAM. The last thing you want to do with a Jehovah's Witness who refuses blood products is to have to go back on pump, reclamp, and replace the valve. So, as a preemptive strike, I did Alfieri stitches in all